So this is basically a summary of all the guidelines available in this on this planet. So these are just 5 to 6 slides which will give you an overview. Like we have the Endocrine Society, which we consider as our Bible, and then we have the American Neurological Association, we have the International Society, and the British Society for Sexual Medicine. So these are the basic tenets on which we are being guided in being treated for hypogonadism. So these are the guidelines, as I said. If you look at the overall philosophy, I've just collated it together to give you a brief idea, not into the nitty-gritties of the matter, but just to give the impression how they deal with this particular case. So Endocrine Society is very conservative, disease-based. American Urological Association is pragmatic, somewhat balanced. The International Society is symptom-oriented, and the British Society is very lenient, is most treatment permissive. Diagnostic cutoffs, Dr. Unikrishnan and Dr. Sahar already mentioned. So there's a lot of debate on which value we should take. That's why Endocrine Society has not committed itself to a particular stick value. The other associations have given a particular value. So you can see BSSM is the most permissive, where we are triggered to treat at a very rather relatively higher level, which they consider to be the lower end of the spectrum. Role of free testosterone, will come to that in the questions. Borderline testosterone approach, there are some issues. Fertility obviously is important because many people tend to forget that when somebody is contemplating to have a child for the progeny, testosterone injection may increase the performance but may reduce the outcome. So progeny creation may be a
It will
problem.
reduce the sperm count.
Exactly, sir. So this part also needs to be understood and need to be asked to the patient, are you planning for a family? Cardiovascular risk, something has already been discussed. I have put in the questions. And lastly, I would say one line takeaway. In Endocrine Society, prove the disease first. Americans, what they say, treat when it is clear cut. ISSM says symptoms matter the most. So out of the symptoms and signs on which we base it, they may be putting a more weightage on the symptoms. If it matters to the patient, then you will treat. And the British Society says treat borderline and judge by response. So with that, now I come to the question set. And this truly has to be a rapid fire round. Yeah, so this thing has gone.
Well, you can ask the question, how many agree?
Yeah, so I have prepared it on a like
Strongly
cards.
agree.
Yeah, so this is
Go back to the slide when you showed the evidence.
Okay.
Next slide.
No, the next slide.
This has not been
It's not
projected.
moving.
This one.
Yeah.
This
So
is-
I think you ask how many strongly agree, then you go back to agree, then you go back to neutral,
Okay.
then disagree, and
So from green
Dr.
zone to red
Puneet and
zone.
team write down the.
So you register the responses accordingly. Yeah. Goes, it passes. Yeah, we'll pass to the next question. Okay. So we start with this. Testosterone deficiency is common in men with type 2 diabetes. We start from the green end. How many of you strongly agree to this? So, Puneet ji ko jaldi calculate karna.
8% is quite a significant, I mean, the lower end, studies have shown more. So 8% is quite common, makes it quite common. One out of.
Asked only strongly. Now they agree.
Yes.
How many of you strongly agree? Everybody. There's only one person.
Supratik.
You're not said it.
You disagree? Agree. You? Huh? Agree.
Okay.
So
So agree how many are.
Agree how many? Only agree.
no, I'm saying strongly agree.
You have not told your. You have not.
No, he raised his
I
hand.
raised my hand for strongly agree, but I have a habit of doing like this. So
We have most people coming into this strongly agree and
Strongly
agree.
agree. Okay.
So we move on to the next. So
Okay.
this is quite. I mean, everybody agrees on this.
Great. So men with type 2 diabetes should be routinely screened for testo deficiency. How many say strongly agree?
if you don't screen, they will suffer in silence.
Routinely. Routinely.
No problem.
Huh.
I strongly agree. You
Without
can
him,
say.
nothing.
I get your point.
strongly agree, but there are other options.
What about agree? Yes.
I'll put there.
Should not be routinely
So neutral.
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 Routinely is the
So
wrong
1% neutral.
Okay. No, not wrong word. You give your answer accordingly. Yeah.
word. I think see
This statement, you are on 3.
No, there's no right or wrong. You just have to grade the statement
Yeah.
according to your view.
So I think so one point what we
Just disagree.
I disagree.
Strong.
so so
Okay.
what happens is that when you have a disagreement on this, we
Yeah.
asked his comments.
Yeah.
We see whether by changing the wording, would he move from
Would he change the fence?
yeah
Would he?
would he change to agree?
Okay.
So we'll just ask him what he feels and
If you take out the word routinely,
Then I'm fine.
okay.
Supratik?
Make it should be symptomatic.
Okay.
Symptomatic patient should be screened.
Punitji, just note down because I don't have a pen. Just routinely word has to be.
so if the word routinely, because there's a little disagreement on this, a few people are disagreeing on that, and they are also going to agree.
Fine.
If you are taking out the word routinely.
Routinely is
If you
little
take
bit
out
rigid for
routinely,
them.
then
Okay.
everybody agrees.
Okay.
Anybody
Okay.
disagree?
Supposing you
Huh?
take out the word wrongly.
Ah.
Very strongly agree.
Yeah.
So let's take off the word routinely and ask again.
Exactly.
So imagine.
So
No, wrong or right is not the question. It's
No,
just
there's
your.
nothing right or wrong,
It's
but what
nothing-
we are saying is that no.
The process. So
This is a process of consensus building. This is a process of consensus building.
Purohitji, what
where
I'm
we are
saying.
saying that if we are taking off the point,
Ah.
I mean the word routinely, then everybody is agreeing to it. There's not a single person who's disagreeing with it.
I get your point.
No, what Purohitji, everybody is agreeing when the word is removed from there.
No, but we are arriving at a consensus. So when we are arriving at a consensus, we should make all efforts to
Put everybody on board.
Get everybody together.
So when you put the word routinely, then you have to define when. You have to define every visit, everywhere, first diagnosis, then that definition has to
Right.
be defined.
So point is well taken. We'll
Yeah.
keep it should be screened for testosterone deficiency, and everybody strongly agrees.
Okay. So next question, screening for hypogonadism should be age-based in men with type 2 diabetes.
See, here we cannot change this wording. It should be age-based or should not be age-based. How
That's-
many people strongly agree with this? This is strongly agree. Now agree. How many people agree? Anybody neutral? Anybody disagree?
Neutral.
What?
Neutral. Anybody disagree?
Supratik?
Yeah.
What are you saying? No. What is your point? Agreeing.
So 1 year, 2 year here and there, whatever I mean. Because we don't have any hard evidence.
Epidemiological studies have shown that hypogonadism, functional hypogonadism, is not very strongly associated with either presence of diabetes or
Yes.
duration of diabetes. But possibly.
But the question is very simple. Should it be age-based or you should screen everybody from the age of 19-year-old type 1 diabetes? You'll to screen them. Should age be a consideration or not? That's all the question is.
It's a binary, yes or no. Then
It's a yes or no question. And how many people strongly agree we've recorded? How many people are neutral on this? How many people disagree? 2 people disagree.
two people.
Anybody strongly disagrees? Nobody. No, we are only taking marks. We are only taking marks. Next question.
Yeah.
Next question.
Okay. So obesity.
Wherever possible, we try to.
Obesity increases the risk of hypogonadism in type 2 diabetes.
How many of you strongly agree? So all unanimous, 100%.
So I had to put some questions where everybody will agree. Okay, so poor glycemic control is associated with low testosterone levels.
ठीक है. Agree करो. I'm not sure about the evidence.
Not sure.
Neutral.
Okay, neutral. We can agree on neutrality.
Diabetes is associated with
Yeah.
testosterone. That's a better one. Poor glycemic.
That's already in the question, Mithun. So it's another.
Even so the thing is, it may be a confounder because if you have more obesity or more insulin resistance, you have higher sugars. So the higher sugar linked to low testosterone may be a confounder, may not be the cause. So I think there are few people who agree and mainly neutral.
Okay.
Next.
Hypogonadism is underdiagnosed in Indian men with type 2 diabetes.
How many strongly agree?
Great.
Next.
Early identification of testo deficiency improves overall patient outcomes. Strongly agree? Strongly agree?
Agree,
Okay.
agree.
Okay. Oh, agree. Okay. Take.
We can combine 1 and 4, I think. Because there's no difference.
Okay. Screening for hypogonadism should be part of comprehensive diabetes care. Mithun's question. First patient has come,
How
first
many
visit, all
strongly agree?
visits, everything included.
Only 2-3 people agree. How many agree? How many are neutral on this?
Yes, neutral.
How many disagree? How many strongly disagree? Nobody. Okay.
Okay.
He's got a mic there.
Should we be hypogonadism? We have to define. So we should have a definition. When we are coming with we should define what we mean by hypogonadism. Are we saying screening in oral questioning by Adam questioner, or we are we are doing IEF scores, or how are we defining? Once we define, life becomes easier.
So do you have questions on that?
We have in
My
the
concern
process.
is not that. My
Huh.
concern is not that. My
Hmm.
concern is that if you are doing in a comprehensive diabetes care situation, we don't have to add this test and treat everybody in that group,
Right.
We can use our clinical judgment and decide whom you want to test and treat. Making it part of a diabetes package is just looking at, doing so many tests so that you can treat so many diseases, and it will increase the pickup of diseases which are not symptomatic. So screen is comprehensive, including there. Maybe I have a problem.
So in my clinic, I only test when I've committed to treat. Okay, if I'm not committed to treat, I will not test.
The other way I'm looking at it is what Uni says is that when he says comprehensive diabetes care means a package. I'm thinking comprehensive diabetes care doesn't mean a package. I'm going to use my discretion, but I keep in mind that this is to be looked at. So comprehensively, I'm looking at it, but I may not do testosterone in every patient. That's how I'm looking at this statement. So how many people agree with that? Yeah, I mean, if you're carrying it to a package or routinely doing something which is even before coming to you that is done, I don't agree with that.
Okay, no, I also agree with
So ultimately, my purpose is getting served.
Yeah, so that's what I was saying, that we need to discuss out certain things to, in the discussion, when you write this,
Yeah.
when we have made some statements,
Yeah.
but we have to substantiate those statements. When we substantiate those statements, these points have to be put in. That we
Included,
are not
right.
saying that it should be a pack which comes for every patient, but we should keep this in mind and
Customized to the specific
Yeah,
patient
yeah.
we are dealing with. Both. It's both, sir. Symptoms plus signs.
that includes both
Symptoms and signs.
symptoms
Yes.
and signs.
Yeah. Biochemistry. Plus
Plus
biochemistry.
biochemistry. You've got an Adam questionnaire.
We are having questions, sir. These questions will come up. The things which are coming in your mind have also crossed my mind, so I put accordingly. So this is the next question. Symptoms alone are sufficient to diagnose hypogonadism in type 2 diabetes.
How many strongly agree?
Strongly
How
disagree.
many agree? You agree, means based on symptoms you will diagnose it. How many are How many are neutral on it? How many disagree? How many strongly disagree?
Here, yes.
Chalo. ठीक. Chalo, next.
Okay.
And make it
Sir, there
reverse.
is no need to rephrase because here this is internal. The scores are coming that we are all agreeing on this point that we are strongly disagreeing.
Yeah,
That
I
part
think-
is crossing 75%.
Agreeing to disagree is important here.
Yes.
Because we are agreeing to disagree that this is sufficient to diagnose.
The consensus what we should put is symptoms alone are not sufficient.
Yes, that will go in the reverse order, right. Biochemical confirmation is mandatory before initiating testosterone. So obviously this is a corollary of the
Strongly
last
everybody
question.
agrees.
Yes, everybody agrees to this.
Anybody not raising hand, we'll ask.
Purohit sir, you didn't raise your hand. Oh, ach.
No, you are also a participant. You have to raise your hand.
Dhruvi is having high cortisol for the next session.
That's the next session, No, waiting for us to finish.
Okay.
Come.
Yes, free or bioavailable
See,
testosterone is
we are
more.
not looking at cortisol deficiency. We are all cortisol sufficient, so we are looking at testosterone in the context of cortisol sufficiency.
Okay, so this free or bioavailable testo is more clinically relevant than total testosterone. This is a muddy area, so how would you phrase this?
I completely disagree because total testosterone is a simple,
Yes.
available, reasonably good test to do.
So I strongly disagree.
I think you
But how many, we'll take a call, how many strongly agree with this statement? No, let's take the number roughly. How many agree with this? How many are neutral on it? How many disagree with it?
Disagree.
How many strongly disagree with it? Strongly.
No.
So Dr. Puneet's team, are you writing down? Okay.
Dr. Uni, we can just put a statement. If equilibrium dialysis method is available, then it can be a better.
Yes, that we'll put as the expert comment on this.
Then it becomes a more magic.
And that's also
Absolutely.
another point that
Next.
when it is borderline, you should actually go for that. When you're in a dicey situation, you are looking at the third umpire for a decision.
The appropriate way of measuring it.
Yes, of course.
That's the important.
LCMSMS gold standard, next equilibrium dialysis, but we are good to
But-
do with CLIA,
But
which we are doing.
in today's scenario, in the way we are practicing, I'm not very confident of the free testosterone.
Exactly.
That's why I'm strongly disagreeing.
And researchers tell that is quite not validated in many of the studies. So the variation is also
This is Vermeulen formula, we can do SHBG.
SHBG index. Yeah. Okay. So repeat testosterone is necessary to confirm hypogonadism. Strongly agree, everybody. So let us go to the next one. LH and FSH measurement is essential to classify hypogonadism. Strongly agree. Okay. SHBG measurement is useful in diabetic men being evaluated for hypogonadism. Agree. Strongly agree.
We'll have to strongly agree how many people raise their hands. How many people raise their hands for agree? How many people are neutral?
I will be neutral.
So how many people disagree? Nobody. How many strongly disagree? I think we'll have to rephrase this question because most people are neutral.
Okay.
I think SHBG measurement is useful in
In
selected,
specific,
in
selected.
specific situations where diabetic men are being evaluated for hypogonadism.
Okay.
How many strongly agree with that?
Can we, sir, can we
Like obesity.
Can we mention about borderline borderline total testosterone, which is mentioned in the studies? In those cases, we can
Saying is in specific situations it may be
Helpful.
obesity. Okay.
We can write like obesity, like you said.
Yes.
Like
okay,
obesity.
okay.
Diabetes.
Abhichandani, you're leaving.
Like Sir has said, there are
We want you to be here.
The word like.
Okay. Morning
next question.
testosterone is sampling is important for accurate diagnosis.
So the usual recommendation is
Yeah.
8 to 10
Okay.
a.m. is
Great.
considered to be good. Any
It should be that it should be only there's no not
So-
reliable. It is the only tool. It's the only tool.
it's important. So it's important, right? You can change it to mandatory if you want.
Okay, Mitran will make it more hard, more assertive,
Morning
and
test sampling
okay.
is mandatory
Okay.
for accurate diagnosis.
Puneji, please write this. I'm not having papers here. Androgen deficiency questionnaires are reliable screening tools in clinical practice. Questionnaires.
Question is are they reliable? We are not saying that it is practicable. It's not practical to do questionnaire, but is it reliable or not? How many of you think it is reliable? How many of you strongly agree? Yeah. How many of you agree?
Agree to
Most people agree. I think.
agree.
Anybody neutral or disagreeing on that? No.
Okay. Testosterone therapy should be offered to symptomatic hypogonadal men with type 2 diabetes.
I agree.
Yes.
I think anybody who doesn't strongly agree.
There is no option of super agree, Kaushik. Of course, yeah. This you are proving means you are seeing both of them. Okay. Testosterone replacement therapy should be initiated only when biochemical and clinical hypogonadism coexist.
How many
Almost
strongly agree?
all agree?
Rephrasing that.
Same
Yeah,
thing.
same, almost same. Yeah.
We are double hit.
Okay. Borderline low testosterone levels warrant consideration of TRT in diabetic men.
Strongly disagree.
Borderline low testosterone.
Strongly disagree.
So how many people strongly disagree to this? How many people disagree to this? How many people are neutral on this? Borderline थोड़ा treat कर लेंगे. आप treat करेंगे borderline को? फिर भी neutral means I may treat, I may not treat. We should be disagreeing on this, like irrespective. Maybe in this case you should consider not symptomatic.
मिथुन जो बोला है
Consider symptomatic.
जी 1 mg से रिपोर्ट आ गया बॉर्डर लाइन है तो व्हाट टू डू सिमिलर थिंग्स हैपन हियर नो दैट्स ओके दैट्स
So the discussion that follows, the discussion that follows the question, I mean, we are saying that when we write the concerns, we are writing a negative of this. I mean, we are writing borderline test does not warrant consideration of TRT in all men with this thing. And then you write that, that you have to look at the symptoms and you should not just go by the, reports which are.
That will be
So
there.
I think that's the discussion that will follow then.
Okay. This should be avoided in asymptomatic men with low testosterone. Therapy should be avoided in asymptomatic people with low.
How many strongly disagree? Disagree. How many disagree? How many are neutral?
Disagree means you want to treat. You want to treat. Disagree.
I started from disagree now. Okay, I'll start with agree. TRT should be avoided in asymptomatic people with low testosterone. How many strongly agree? Agree.
Yes.
Why are you make it a very simple English, na? Negative, two negatives you make.
That's the thing.
Okay. Okay. During the discussion, we'll
But I
pick
think
it in the
that's
next
important to avoid it. ऐसे देना ही नहीं चाहिए.
ऐसा देना ही नहीं चाहिए.
Question number 20, delete. Just write down, please.
Next question.
Contraindications. Age alone should not be a contraindication.
How many strongly agree?
Done?
Strongly agree.
That shows our mean age is high.
Functional hypogonadism in obese diabetic men merits TRT. Obese diabetic.
How many disagree? Strongly. So others are agreeing that you will treat them with testosterone, even with functional. Huh?
Yes. Yes. The axis is normal. Exactly. The axis is normal. Just some other thing.
So everybody is agreeing to that or not?
So let us take a vote. This one? Last one?
No, previous one.
This one. Yeah.
Functional hypogonadism in obese diabetic men merits TRT. That means that you are going to treat them, even if they're obese, they have got a functional hypogonadism where the lab reports are normal.
So I strongly disagree.
So how many disagree to that?
Disagree.
Strongly?
No.
You're not voting, Ganesh. Balaji. You're not voting.
No, lab is normal. Your symptoms. Functional hypogonadism is saying testosterone levels are normal.
Disagree.
Yeah, functional, yeah.
It may be due to say drugs. It may be due to CLD.
Yeah,
it may be
but
due
the
to
level is low.
Huh.
Level is low. Patient is having some other reason for hypogonadism. It's not true hypogonadism.
Right. So
Capacity first. If it doesn't resolve, then
Idea ki first this or that.
the point
So-
is, whatever statement we are having, we have to define that. What do you mean by functional? What do you mean by symptomatic? What do you mean by symptomatic?
Yeah. Can we rephrase the statement? We say that functional hypogonadism in obese diabetic men. No.
Bilateral relationship. What Dr. Mithun is saying is also true. A patient can able to lose 10% of body weight by just lifestyle modification.
Yeah, that's right.
See, that agreeing that question, you are telling that testosterone is an anti-obesity medicine. Do you agree on that?
Yes.
So, I do not think.
Where is the evidence?
What is the evidence?
Where is the evidence?
What is the evidence of testosterone?
Because I was involved in the last trial, that's why I can tell you that for the extended study, there is no, and even in the T trial, you see that what we say or what we assume that yes, waist will circumference will completely improve or fully come down is not a mandatory rule.
Functional means that the patient
What-
has
We are talking obesity.
No, no,
We're talking obesity.
This
We're talking
question
obesity.
means you are telling testosterone is an anti-oxidant.
30% of
Is this question creating discord?
Yes.
So should we remove this question or
No, no, we
rephrase the
should
question?
rephrase that. We should rephrase that.
Okay.
What we are saying is that functional hypogonadism in obese diabetic men does not always merit treatment.
Does not always. Does not always. That-
Does not always merit treatment.
do we treat functional hypogonadism?
That's what we are saying. You look at it case to case basis. You may not always need to treat. You may treat one or two patients, but you may not treat everybody.
May is a
Question number
may is a
लिखिएगा.
word.
Yeah, yeah. May not always merit treatment. That's it. So there may be a couple of people who may require treatment. You may treat some of them, but you may not treat most of them. Most of them, you'll advise them to, do other things to improve their metabolic status, and they are improving.
Okay, so we should.
Again, sir. Answer me again.
These words are
Kaushik had already mentioned this.
Yeah, yeah. Yeah, but that is the answer to that question.
So I have everybody's in mind here when I made the questions.
In obese patient,
Huh.
you have to define this.
Yeah, if the BMI is 16
Weight loss.
or weight loss करके आओ.
In obese patient.
In obese patient.
In obese
Okay.
patient, obviously,
Yes.
that has to be added. So is it being recorded? I mean, are you
I
writing
thought
down
it's a corollary. When
question
I'm
number
talking of weight
23?
loss means I meant. Okay, anyways. We'll rephrase it.
Assume that this is an obese or overweight patient. We will change it.
Sir, yeah, no, but when we are doing a consensus like this, we can't assume things. We have to be very precise and we have to write those things.
Okay, we'll put the adjective. So obese patient.
Before restoring the HPG axis, you have to lose at least 15% body weight. So you have to mention that.
Obese, right?
Yeah, obese.
Huh.
We have to put obese first.
Okay, we have come to the midpoint almost. Hypogonadism is a treatable cause of sarcopenia. How many believe this or disbelieve this? Hypogonadism is a treatable cause of sarcopenia in type 2 diabetes.
How many strongly agree to this? Nobody. How many agree to this? 2 people, 3 people. How many are neutral on this?
Yes.
We need to rephrase it. We can't have a neutral statement here.
Hypogonadism is one of the many treatable causes of sarcopenia.
Okay.
But are there any other treatable causes?
Hypogonadism is one of the important treatable causes. Is it okay? Does everybody agree if we say that? No, if we put.
Maybe we lack of maybe we could say sarcopenia may improve in some selected patients.
Some people say now
Yeah, but-
GLP
but,
therapy.
the
There are
statement
studies now going on.
Hypogonadism is one of the treatable causes. One of the.
I think what you said.
Yeah, but do we have evidence that by treating hypogonadism, your sarcopenia improves?
So the muscle strength is a T trial. In the T trial, there is some evidence.
Lean mass improvement is there. Muscle strength improves.
If hypogonadism is responsible for the muscle loss, so I'm going to treat that.
Yeah, so we are saying that hypogonadism is one of the important treatable causes of sarcopenia.
Treating hypogonadism may improve sarcopenia in type 2.
That is more simple. Yes. Yes.
Have you kept anything on treatment again later on after this?
It's there. It's there.
It's there. So,
Ah,
no,
so-
so then this is a generalized statement before we come to that one.
Okay,
So here we are not speaking about treatment. We are speaking whether it is one of the causes for for sarcopenia.
Okay, so whether we will keep the treatable or not, whether we'll keep this in the anvil to treat, that's what you're asking. Yes, okay. Okay, that will be put there.
Hypogonadism may be a treatable cause of sarcopenia.
Okay. Okay, next question. As specialists in diabetes care, do you routinely manage hypogonadism with testosterone injection? What's the vote of the house?
Routinely.
Do you routinely manage hypogonadism, which you are obviously investigating, with testosterone injection?
Diagnosed hypogonadism, do you treat with injections?
फिर से बोलो.
Diagnosed hypogonadism, when treated, will you treat with injections? Now, when you say injection, testosterone injection, you have to define.
You may-
monthly or 3 monthly.
Yeah, you may also do
तब
it
तो
orally
क्वेश्चन
also.
दूसरे तरफ भी जाएगा
नहीं,
कि ओरल देंगे कि नहीं
Oral भी दे सकते हैं ना,
हाँ
oral भी दे
that
सकते हैं.
question
So why
will
do you
come
want
up
to?
then
हाँ, patch भी
पैच
है,
भी आ रहा है
patch भी है. You've got so many ways of giving testosterone.
Okay, let me rephrase it like this. As specialist in diabetes care, do you routinely manage hypogonadism with any form of testosterone? How will you react to this? That's okay? Okay, fine.
कोई इंजेक्शन उसने इसलिए लिख दिया कि वो इंजेक्शन ही देता है।
Obviously, okay. Okay. Second question is almost a corollary of that. As specialist in diabetes care, do you routinely manage complex endocrine cases like which say hypogonadotropic hypogonadism,
No, but
late onset?
No, but what is the purpose of these two questions?
Whether you are routinely
No,
treating.
we are not assessing the group, na.
Okay.
So why do you want to keep these two questions? These
So-
two questions are not required.
These two will be out,
Yeah.
as you say.
See, that is the idea that we should up to a point we can manage, and the others we can refer out to somebody else like hypogonadotrophic, weekly injection, so those kind of things.
Okay.
So, huh? No, that's a question. Are you managing? Okay, so you can answer yes.
That's what I asked. Whether
So how many people would routinely manage complex endocrine conditions like hypogonadric hypogonadism here? So I think we leave it. We'll go to the next question.
Sure. TRT improves insulin sensitivity. Would you agree to this? Agree? Okay.
We'll keep all these questions.
Okay. Leads to improvement in HbA1c. There are some caveats here. Okay, so there are some issues. So actually, what happens, what the study said, what Mithun quoted actually in that study, it's discussed there that the conversion from the T4DM study, 40%. But I'm saying one of them. It's discussed. It's mentioned in the discussion part that HbA1c is not seen to be improved because as soon as you give the testosterone, there is an erythrocytosis. The half-life of the RBC is changing. So whatever you gained, that is compensated by the loss. So HbA1c stays at the same level. So this part actually has to be kept in mind. कि अरे report में तो change ही नहीं हुआ. So this part has to be kept in mind. Okay.
Level. And secondly, he also mentioned Traverstan, which failed to show any benefit, glycemic benefit.
ट्रैवर्स में तो और प्रॉब्लम है वो तो जेल हुआ था टेस्टोस्टेरोन को तो कार्डियक सेफ्टी मिल गया तो उसको बेल मिल गया लेकिन
Jail, sorry, I missed it.
No, I said I just fought in a debate. I'm mentioning that. So that's it. That in 2015 the black box warning came that cardio was. I'm just mentioning that. So now 10 years down the line, that CV part is said to be non-inferior, but 3 more problems cropped in or creeped in. That is atrial fibrillation, the AKI issue at GFR of 60, and what was the third one? Thromboembolism. So these 3 things actually are now completing the scenario. So, okay. TRT reduces visceral adiposity.
Strongly agree or agree?
Agree. I will agree.
Yeah, of course, with hypogonadism.
Okay, in every question that will remain, right.
I think
Actually,
this
these
question
questions
should-
are internal.
this should be
that will not
qualified
go out to
with
anybody.
hypogonadism.
Okay. Comment about the lipid profile changes, whether you would comment.
This is also with hypogonadism.
Of course.
Strongly agree. Only thing it lowers the HDL.
HDL problem
It lowers
may
the
be there.
HDL.
Yeah, that's why when they say lipid profile, the HDL also comes.
I think then we should.
We have to define it.
TG improves, LDL improves, but HDL may come down. So that part,
Exactly.
but researchers
So
mentioned.
why don't we score neutral on this and qualify this in the position statement saying the pluses and minuses?
You will mention it then that this can happen. Okay. Contributes to overall metabolic health in hypogonadism in type 2 diabetes.
Me.
So neutral or agree? Neutral?
No, in hypogonadal type 2 diabetes, TRT contributes to better overall metabolic health. It's not saying TRT is causing better. It's just one of the contributing factors. I mean, there's no.
Yeah, then I
It
think
contributes.
may. That's why I said may. When you put a may,
Yeah, yeah.
something like
Okay.
I think may contribute.
May contribute.
May
May
contribute.
contribute.
Everybody
Okay.
agrees.
Okay.
Yes.
I'll leave this question. This is already there. Glycemic benefits of TRT justify its use in selected hypogonadal type 2 diabetic patients. I'll say neutral.
Yeah, we are actually. No, but
already said selected.
Yes.
the issue is
Which? Yes. Okay.
But that doesn't justify its use. There are other drugs for glucose.
So this is
today-
not an anti-hyperglycemic
today you have
agent.
got so many other drugs that would you keep testosterone as a therapy
No.
in a person who is poorly controlled?
Is this-
He is hypogonadal, but yeah. So I think yeah. So
Actually, the next question mentions, sir, what you are saying. That's next. This is the next question. Right? Obviously.
yeah. So
That's what we
obviously
discussed.
everybody
That-
agrees on
Yes, okay, okay. So after a long time, I got all the hands up. Improves libido in men with type 2 diabetes, hypogonadal. Okay, agreeing. Okay, fine. Improves erectile function in hypogonadal diabetic men. Both the desire as well as the performance, both. Okay. Please elaborate on this. Yes.
But most of the cases there is improvement in sexual desire, but erectile dysfunction
Neuropathy.
may not be improved because
Neuropathy.
underlying neuropathy,
Yes.
vasculopathy. So most of the erectile dysfunction in type 2 diabetes is not because of testosterone deficiency.
Yes. So should we put it like this, Kaushik? TRT may improve erectile function. Okay. This point will be mentioned that there may be associated vasculopathy and neuropathy which might not reap the benefits of testosterone therapy. Okay. ना will control से तो मतलब नहीं है 15 साल डायबिटीज है तो न्यूरोपैथी तो ऐसे ही है तो that is something
controlled है तो still
still may have no with okay it improves energy levels and fatigue for which we put the questionnaire Adam square something so energy level fatigue it can improve
Hypogonadal men with type 2
yes
diabetes.
in
it will
every
improve the
question I will
level.
put that yeah due to shortage of time I couldn't write
everybody agrees to that.
okay mood and sense of well-being in type 2 diabetes hypogonadal
Anybody disagrees? We'll now ask the reverse so that.
Neutral, sir. Neutral, sir.
Hmm?
I don't know.
okay neutral so we all agree on this neutrality
Why I'm telling you, I'm backing it with the evidence of T trials. Look at the T trials.
Testosterone, no female is there.
No, there is no
cortisol
She's voting in this. No. But she's voting. She's voting.
सर आपके साथ एक फोटो
पहले सबको मैं ले लूं. I just wanted to take that.
So, Dr. Puneet,
Sir, cortisol is already high in that consensus.
T trials का evidence निकालो. T trials have defined a sub-segmented of each of these answers with the evidence. How much strength, how much quality of life.
We'll finish soon, Dr. Banshi. The
5
next one is
questions.
going to
Yes,
start.
okay
So I think
patients
this we will, please, we should include Dr. Mithun also in the.
okay patients report high satisfaction with TRT will you keep it
In hypogonadal type 2,
in
yes.
hypogonadal type 2
Yes.
okay
Anybody disagrees? Anybody disagrees on that?
What satisfaction is getting.
for which he has come and complained to you
Actually, go by the study, we'll see that sexual desire improves.
Yes.
Some erectile dysfunction improves,
desire
but
improves.
other domains of sexual areas are not very improved with testosterone.
Some muscle strength may not improve in a lot of people.
right that's taken
So some quality of life 1-2 दिन तो अच्छे निकलेंगे ना.
यार ऐसे थोड़ी ना होता है यार ये थोड़ा
ऐसी वो नहीं हो जाता यार.
ठीक है okay so
ये भी तो और भी खराब है, आग जलाने के बाद अब पानी भी डाल दे रहा हूँ. बेचारे क्या करें?
okay
इसीलिए dissatisfaction है. That is the biggest dissatisfaction point. Because the desire goes up, the erection goes, is not satisfactory.
or frustrated okay
That's just things you are talking ना. For patients तो it was good thing है.
Patient आएगा तेरे पास.
okay
Anyway, we are qualifying those points in the discussion.
now comes the
next.
important part which we already discussed cardiovascularly safe in appropriately selected diabetic patients as on today's time 2026 you agree All of
Everybody agrees. Any disagreement?
okay.
No. Okay.
Increased prostate size is a relative contraindication for the use of TRT. Yes. In relative. I mentioned relative.
Perfectly get blurred. How much increase?
How much PSA rise? How much on digital rectal examination?
But is it a factor or not? It has to be taken into account.
Severe lower urinary tract symptoms with enlarged prostate, that is a
So
contradiction.
basically, the guidelines of American Endocrine Society, they said, or other societies, the rise of 1.4
Yes.
after testosterone treatment from baseline.
1.2 per year or more than absolute, more than 4. Anyways, yeah, okay, yeah, okay.
So if that is there, you don't do a routine ultrasound to look at a prostate size to decide. In fact, in blood symptoms, some people may get improvement also.
Without PSA, how can you talk when there is no?
So when you say prostate size, nobody will do a digital rectal examination in this room.
Yes.
sonography.
Yeah. So why would you do a sonography?
And sir, one guideline
You'll not do a
is there,
sonography,
European
there is no-
guideline is there. If an endocrinologist do a digital rectal examination, it could be harmful.
Yes,
It has been
because we are our fingers are not trained. That is the point.
Are you are
No, it's absolutely correct actually. What you said is absolutely correct. You are not supposed to do.
The point here is to put some checks and balances where we should be careful. That was the main.
Elevated
We-
PSA.
To what level we can do? See, why this is important, this consensus is whatever you write, tomorrow somebody may use it to justify their practice and
Yes,
something will go wrong.
exactly.
We have to be extremely responsible. You know, many years ago, I gave a talk on duloxetine for neuropathy when duloxetine was launched. After giving the launch lecture, I came back. Next day, I was sitting in OPD. I got a call from the security of the hospital that there is a patient who is coming with your CME invitation to see you. So the patient came to me, not next day, after 2-3 weeks. So the patient told me that my doctor has written this prescription based on your lecture, he says, and I developed hematuria after taking this duloxetine. So now I've come to you. What is the solution? Is it related? Is it not? And the patient has got my CME invitation in the hand. So it has got that much importance. So whatever we write tomorrow, remember, even the most aggressive of doctors may use this as an excuse to overtreat. If they miss it, it's okay. If they get into trouble, we don't want. So that is how we should position it.
so, but was that hematuria because of that?
No connection. But the doctor could not withstand that pressure from the patient. आपने ये दवाई लिखा, नया दवाई है, कैसे हुआ? Then the doctor said, अरे आप डॉक्टर उन्नीकृष्णन से पूछो, CME उन्हीं ने किया. So similarly, our consensus may come in court also. Somebody gives testosterone, somebody gives, somebody may testosterone, it may get sued. All this happens. They will cite there is a consensus statement based on which I wrote this. So that can be.
Baseline
But he's
PSA,
not qualified
PSA
to write
monitoring
now.
should be like essential during
Raise PSA, we can mention
And
the
monitoring.
contraindication. And means prostate size beyond a certain level, it comes on ultrasound.
Baseline PSA also has to be
So
included.
we'll keep
yeah.
it like this so that over treatment is not there, but we'll qualify with the PSA and the testosterone level in sentences as an add-on to that opinion.
Coming to the next side effect, hematocrit monitoring is essential. Of all of you agree?
Yes.
Okay, fine.
Anybody disagrees? Anybody disagrees?
No.
Okay.
So we're
Routine monitoring of liver function. Is it necessary for patients on injectable testosterone? In the absence of pre-existing hepatic disease, just because of this drug, can it damage the liver?
So baseline. So you can say baseline monitoring should be done.
How can you monitor?
Baseline monitoring, but
Baseline.
that's okay. So lastly, benefits of TRT outweigh the potential risks. Do you agree to this? I would still say I will not agree. Maybe neutral. Okay.
But it's selected, appropriately selected patient.
That we will write underneath that, sir. That it's selected, it may be good, but
Appropriately
appropriate.
It should be avoided in diabetic patients with CV disease, like untreated heart failure, recent MI, stroke in the last 6 months. So these things have to be kept in mind for the practicing doctor. So
How many strongly agree with this? Somebody agree? I'm sort of neutral on this.
okay.
But I agree that it can lower the HDL, it can cause fluid retention. Well known. Sorry? Yeah, I'm also neutral on this.
No,
Be
then why am
avoided
I
or can be
asking,
given? Can be.
Mithun, then why will I ask, should be avoided in stable diabetic disease? Okay. Acha, you are rephrasing it. Okay, got it.
So
Fear of,
rather you should say, if you want to write about avoiding, you should say then those with unstable cardiovascular disease, it should be avoided.
okay, so finally we come to the end. Current guidelines provide clear-cut guidance on TRT in type 2 diabetes. How many of you feel that we are having a lot of
No.
clarity? So that's
No.
why the consensus is required.
We
Okay.
strongly disagree that current guidelines are not giving a clear picture. So we are trying to discuss that and
Build it up
give more clarity on that.
on this. Okay, fine. Okay, so testosterone therapy should be used selectively in people with type 2 diabetes, and better evidence is required for borderline cases before treatment can be recommended. So this
Yes.
you all agree? And the last question, it is important to generate India-specific consensus for
yes.
clarifying the utility of this therapy in diabetic practice.
Very strongly
Yeah,
agree.
yeah,
Who disagrees with that?
that is a niche
Anybody
on which we build up this consensus. So here we have, so I think all the responses have been taken over. Okay.
So I